Welcome to this discussion about interpretation of endomicroscopy images in the diagnosis of pancreatic cystic lesions. As you know, presurgical differentiation of pancreatic cystic lesions is challenging. It's challenging to classify mucinous from non-mucinous cysts using standard of care parameters. Further, it's challenging to diagnose specific cyst types. Hence, there are multiple guidelines from national and international societies. Most endoscenographers tend to follow the revised international consensus guidelines from 2017. Without going into further discussions involving the various high-risk and worrisome criteria, novel diagnostic strategies have been researched in the last 10 years to improve diagnostic accuracy in the diagnosis of pancreatic cystic lesions. The three foremost novel diagnostic strategies include cyst fluid molecular analysis, that is using next-gen sequencing. Briefly, next-gen sequencing is highly accurate for diagnosing IPMNs. It's not fully optimized for diagnosing mucinous cystic neoplasms and tends to have false negative for serous adenomas. As of yet, there are no markers for cystic neuroendocrine tumors. Through the needle biopsy using the microforceps biopsy has a higher risk of complications, up to 10% of bleeding and pancreatitis. The diagnostic accuracy is dependent on obtaining appropriate representative tissue. EUS-guided confocal laser endomicroscopy is a novel technology. It's optimal for obtaining images for IPMN, serous adenomas, and cystic neuroendocrine tumors. It's somewhat challenging for obtaining images in mucinous cystic neoplasms. Confocal endomicroscopy has two learning steps. One is the procedure itself, which is high quality image acquisition during EUS, and then interpretation of images. Most of this talk will be on image interpretation. At the end of this presentation, one should be hopefully well versed in diagnosing specific cyst type using endomicroscopy images. Here is the basic setup for EUS-guided needle-based confocal laser endomicroscopy. There is an endomicroscopy processor to which the probe is connected to. The endomicroscopy probe, otherwise called the AQ-Flex probe, which is less than 0.9 millimeters, is preloaded in a 19-gauge needle. Typically, we use the Boston Flex needle, which is a nitinol needle for flexibility. Once we see the cyst of interest, the needle is actuated into the cyst, and then the probe is advanced and locked in position. With a gentle movement of the elevator and also rotation around the body axis, you can move the probe in different locations of the cyst as shown in this video. The idea is to gently move across the cyst from one end to the other end. The imaging pattern changes with either tangential imaging as shown here compared to on-force imaging where the needle is more vertical. The image pattern seen during endomicroscopy differs as per the cyst type. We will be reviewing the image patterns of each of the most common pancreatic cyst types. The first cyst of interest is IPMN. IPMNs can either be with high-grade dysplasia where the papillae in the IPMNs are prominent, whereas low-grade dysplasia, the papillae are much thin, flatter, and don't have prominent papillary projections. The IPMNs are lined with epithelium which have a papillary configuration. A typical papillary structure as shown in this picture shows an inner vascular core which is bright because of intravenous fluorescein which we administer to the patient before endomicroscopy. The inner vascular core, otherwise the lamina propria, is surrounded by an outer epithelium which is dark in color. The darkness is mainly because of the nuclei since they appear dark during endomicroscopy. These papillae are seen in various shapes and forms. Here are various possibilities. You have overlapping papillae as shown in figure 1. Figure 2 shows the transection of a very large papillary structure with outer epithelium, inner vascular core. Figure 3 shows a much darker papillary epithelium with some nuclei near the basement membrane. Again, it's a kind of a transection. And figure 4 shows IPMN with low-grade dysplasia. The papillae are thin, the epithelium is thin, and there are multiple papillae in the field of vision. Here are some more examples. In the top panel, you again see multiple papillae in IPMN with various length, thickness, configuration. The key hallmark being that central vascular core and the surrounding epithelium. In the bottom panel, you have the vascularity in IPMN, where you see parallel running blood vessels described as the rope ladder type of vascularity. This is partly due to the papillary architecture. We typically don't use this to diagnose IPMNs, but this is a good supplemental image feature to know when we evaluate IPMNs. Another point to be noted is that we rarely see isolated or large papillary structures, since most IPMNs are somewhere between low-grade, intermediate to proceeding to high-grade dysplasia. As dysplasia progresses, we get to see these large papillary structures, sometimes which occupy the entire field of vision. Here in these videos, you see much flatter, thinner epithelium, a feature of IPMNs with low-grade dysplasia, and you will see IPMNs with multiple papillae. It's overlapping papillae as seen in this video. And sometimes it looks like the gyri and sulci of brain. Another example with some beautiful looking papillae in a case with IPMN. In correlation with the pathologic progression from low-grade to high-grade dysplasia, which involves cellular and nuclear stratification, during endomicroscopy you see that the papillae look much thicker, darker as they progress from low-grade to high-grade dysplasia. Eventually, from thin, flat papillary structures, you get to see this large, dark and irregular appearing papillae. These videos just show the differences between IPMNs with low-grade and high-grade dysplasia. Generally, low-grade dysplasia IPMNs have much thinner, flatter papillae, whereas those with high-grade are thicker, larger papillary structures with a much thicker and darker papillary epithelium. Moreover, the vascularity also tends to get more intricate. From the basic rope ladder pattern where the blood vessels are parallel, the vascularity gets more networked, more intricate. While there are multiple changes that happen in IPMNs, as seen during endomicroscopy, while the lesion progresses to high-grade dysplasia, the key features are the epithelial thickness and darkness. Here is a slide showing multiple IPMNs with low-grade dysplasia on the left and high-grade dysplasia on the right. The idea here is to make you more familiar with the various image patterns that we see during endomicroscopy of IPMNs. The next pancreatic cyst we will review are mucinous cystic neoplasms, or MCNs. The key feature of MCN is visualizing the epithelial bands. These are either singular or they could be multiple in layers. The second key feature is visualizing inflammatory cells. Some MCNs may or may not have these inflammatory cells or clusters of inflammatory cells. Sometimes there could be a dark background suggestive of atrophic epithelium with bright shiny macrophages similar to pseudocysts. What I briefly alluded to earlier in the talk, that the needle positioning does change the way the image is produced. When the needle is more tangential, you get the best images for MCN. The reason is that when you stand on a beach and look at the waves of the ocean, you see the waves much better when you are at parallel rather than en face, where you hardly see any waves. In this video, you see multiple layers of thin, flat epithelium. The inflammatory cells could be seen in clusters or groups. Again, another example of epithelial band in mucinous cystic neoplasm. Occasionally, we see these large, round, isolated cells, which we think are luteal cells, which are a feature of the ovarian stroma. This is hard to prove, but MCNs demonstrate both these large cells and clusters of clumps of inflammatory cells. Again, more examples of epithelial bands seen in cystic neoplasms. Coming up, we will review both cystic neuroendocrine tumors and pseudopapillary neoplasms. Both these cyst types demonstrate the trabecular pattern. We cannot differentiate between these two cyst types just by endomicroscopy. Both these cyst types demonstrate a trabecular pattern, which is nests or clusters or cards of cells which are separated by the stroma of the cyst. Here is an example of cystic neuroendocrine tumor. What we see are cards or groups of cells which are separated by the stroma of the cyst. Some early learners of endomicroscopy might confuse this for the Fern pattern of vascularity seen in serous adenoma, but it's important to note that the spaces between these groups and cards of cells are not filled with RBCs, meaning that those are not blood vessels. This is just the stroma separating these groups and cards of cells. Here is an example of solid pseudopapillary neoplasm. Again, very similar to the cystic neuroendocrine tumor. There are cards or groups of cells separated by the cyst stroma. Here you see more of cards of cells than nests of cells. The spaces between these groups and cards of cells do not have any red blood cells flowing through them. The next cyst type we will discuss are serous adenomas. These don't have an epithelial pattern but rather have a very characteristic vascular pattern, the so-called Fern pattern of vascularity. Here you see multiple blood vessels which branch off from a central blood vessel, and these tend to run parallel to each other. You might see these blood vessels packed with RBCs. In the lower panel you see blood vessels which appear dark. These are packed with RBCs. And in the upper panel you see blood vessels which are bright in color because of much penetration by contrast. In the next few videos we will see serous adenomas with both types of blood vessels where you have a higher penetration of contrast and the blood vessels appear bright, and in those where there is a lower penetration of contrast or the blood vessels are packed with RBCs, hence giving it a much darker color. In this example, you see blood vessels with flowing RBCs. There is a higher density of RBCs at certain areas. There is a very characteristic Fern pattern as described, and here again there is a higher density of RBCs within those blood vessels. In this next example though, you see that the blood vessels appear much brighter compared to the previous example. The last cyst type we will review are pseudocysts. Pseudocysts generally have a dark background with bright particles. The inflammatory cells, typically macrophages, can show autofluorescence. Some pseudocysts though have a very bright background. As seen in this video, you also see poorly organized groups and clumps of inflammatory cells against a bright background. The bright background is most likely due to the exposed part of the pancreas, typically when the needle is too deep. In this example, the cyst background is dark because of lack of blood supply. The bright particles are macrophages which have autofluorescence. In this last example, you see a very poor uptake of fluorescein with lack of blood vessels, and the background is featureless and dark with some autofluorescent inflammatory cells. Now that you have a good idea about these image patterns, we will quickly recap. IPMNs, the typical feature is seeing papillary structures. In IPMNs, they could be really flat with low amplitude, meaning the papillae are much flatter without the typical papillary configuration. Or as the dysplasia progresses, you will see IPMNs with much larger, prominent, darker, thicker papillae. The next cyst type, which is Mucinous cystic neoplasms, have much flatter epithelial bands. They don't have the typical papillary configuration, and more often than not you tend to see clusters of inflammatory cells and sometimes a dark background with bright autofluorescent inflammatory cells. When you group both these mucinous cysts together, that's IPMN and MCN, the hallmark is seeing epithelium. Whenever you see epithelium, that's either IPMN or MCN. Now, it's sometimes challenging to differentiate between MCN and a IPMN with low-grade dysplasia, which has much flatter epithelium, and we will discuss that in the next few slides. The next cyst is pseudopapillary neoplasm or cystic neuroendocrine tumors. Both these have the same image pattern, that is clusters or groups of cells which are separated by the stroma of the cyst. This is very similar when you see the histopathology of these two cyst types. And again, this feature or the trabecular epithelial pattern is only seen either in cystic neuroendocrine tumor or pseudopapillary neoplasm. Serous adenomas, on the other hand, do not have any kind of epithelium. What they have is intricate networked blood vessels, which we see as this fern pattern of vascularity or the superficial vascular network. Finally, pseudocysts, which don't have a true wall, don't have blood vessels within the wall, are typically dark, and they show a lot of inflammatory cells. These inflammatory cells can be autofluorescent, or they could be dark clumps of inflammatory cells seen against a bright background, which is the underlying pancreas. Here are some challenges in differentiating cyst types based on endomicroscopy. The first is differentiating IPMN with low-grade dysplasia from mucinous cystic neoplasm. As stated before, both have thin and flat epithelium. Some low-grade IPMNs may lack the typical papillary configuration. To compare, MCNs have a thin epithelium. The epithelium is flat, sometimes in very thin layers. The background can be dark because of atrophic epithelium, or the background is typically more usually bright and you see clumps of inflammatory cells. On the other hand, IPMNs with low-grade dysplasia, the epithelium is slightly thicker compared to the MCN, and you may see some papillary configuration, but there are hardly any inflammatory cells. You never see a dark background. Note that in clinical practice, it's way more frequent that you encounter an IPMN with low-grade dysplasia than MCN. Again, to compare, here is the video of MCN. There's a background of some inflammatory cells. Again, here is a dark background with some bright particles, which are again inflammatory cells. Dark background means atrophic epithelium. Now you see very flat epithelium, thin layering of the epithelium, which is a diagnostic of mucinous cystic neoplasm. Now here is IPMN in comparison. You see that this is an IPMN with low-grade dysplasia. You see layering of epithelium, and there is some type of papillary configuration, but you can hardly differentiate. But there are hardly any inflammatory cells in the background, and you never ever see this dark background with bright particles which we see in MCNs. Next challenge is differentiating cystic neuroendocrine tumor or pseudopapillary neoplasm, which is the trabecular network, from the typical fern pattern of vascularity seen in serous adenoma. In the trabecular pattern, what separates the clusters and groups of cells is the stroma of the cyst, whereas in serous adenoma, it's a network of blood vessels, and in this network of blood vessels, you tend to see multiple floating RBCs. Moreover, in serous adenomas, within these blood vessels, you occasionally see clumps of RBCs as well. Here is a video of the trabecular epithelial pattern of cystic neuroendocrine tumor or pseudopapillary neoplasm. You see groups and clusters, or sometimes cards of cells. These clusters are separated by the stroma of the cyst. Spaces between these clusters do not have any RBCs in them, do not have any floating RBCs in them. The clusters and groups are in various shapes and sizes. The image pattern is produced because these two lesions are highly cellular compared to the other cystic lesions. Here are 4 different patients with serous adenomas showing the Fern pattern of vascularity. These are essentially the capillaries which kind of occupy the entire cyst. When we do endomicroscopy, these images move very quickly and we get to see this beautiful pattern of blood vessels. Essentially, there is a central blood vessels from which other blood vessels branch off. You get to see RBCs floating within these blood vessels, or sometimes blood vessels packed with RBCs. Since you are evaluating these lesions or the endomicroscopy of these lesions without background clinical features, it sometimes is difficult to differentiate a mucinous cystic neoplasm from a pseudocyst. The key difference is that in mucinous cystic neoplasms, you will see thin epithelium, which is the hallmark. You also get to see these dark areas and clumps of inflammatory cells. Now, pseudocysts never reveal an epithelium, and most of the cyst is either dark with some autofluorescent inflammatory cells. Occasionally, you may see a bright background, which is because of the underlying pancreas, and against that background, you tend to see clumps of inflammatory cells.